So good morning. Welcome to our series, Racism and Race, the Use of Race in Medicine and Implications for Health Equity. This is the second session in our series, sponsored by the UCSF School of Medicine in partnership with our sister schools of medicine across the University of California, San Francisco, across the University of California. My name is Kirsten Bibbins-Domingo. I am the Vice Dean for Population Health and Health Equity in the UCSF School of Medicine, and delighted that you are joining us today. Before we get started on this session, I want to comment on our first session, which took place 2 weeks ago and really kicked off this series. We had three terrific keynote speakers and two panels that really kicked off our series and made up the bulk of the half day 2 weeks ago. We received a large number of comments about our first session, comments that appreciated the high quality of the outstanding talks and scholarship presented, appreciation for the broad expertise of the speakers and discussants and the exchange of ideas on both panels, and appreciative of the format and the venue for creating a conversation on the exchange of sometimes divergent views that we don't oftentimes get to hear in the same time and place. We also received concerns, including from those who appreciated the content, that the tone of the session was not always respectful. We agree, and these are comments that we take seriously. And so I want to underscore two really important points. So the topic that we're addressing today on the use of race in medicine is a complex and nuanced topic that we are trying to unpack. We have intentionally brought together experts and scholars of this topic who have important perspectives that sometimes differ. Discussion, debate, and disagreement are part of the scientific method, and we are appreciative of the willingness of these experts to engage in that work to advance our understanding of this important and complex topic. I am personally very fortunate to have learned from these presenters, many of whom are colleagues and friends, who hold different views. Because many of us have learned and grown throughout this process of exchanging ideas, this is precisely the reason why we think these types of sessions are important. Respect for our speakers and discussants is not only expected, but it is essential if we are to do this work. Our presenters are putting themselves out there on this important topic. They bring their scholarship and expertise. They also bring their own identities and lived experiences. It is critical that we listen to each other in a spirit of mutual respect and do so in a way that more consciously sheds the multiple hierarchies of privilege that we bring to these discussions. These are hierarchies by race and ethnicity, by gender, by academic rank, by institution, and by discipline. Anything that prevents us from fully listening to each other on this important topic will also prevent us from doing this work effectively. So these are the values that we are bringing to this work. My slides advance. They don't seem to be. Oh, good. Here's our shared values. The differences of opinion are expected and are welcome. All speakers and discussants are treated with respect. And despite different views, we have two common goals: advancing anti-racism in medicine and pursuing health and health equity for our patients. So we are in this series examining a small but important slice of race and racism in medicine. That is how we use the concept of race in how we teach, in how we practice, and how we conduct research. We spent our first session laying the foundation with historical and current perspectives. And now what we want to do in this session today and in our session next week is to examine a series of case studies to help us to apply principles and concepts that we've learned about to specific scenarios that we oftentimes encounter in medicine. This brings us to our fourth session on April 28th, where we will really try to stimulate a series of discussions within our mission areas, allowing for small groups to discuss the implications of our sessions for how we teach, how we practice, and how we conduct research. I want to highlight the fourth session because we are really fortunate behind the scenes to have leaders from across our UC campuses who've really come together to start to think about what does the work we're doing today mean for how we will think about race in medicine from an education perspective, from our clinical practice perspective, and from the types of research that we are trying to conduct. And I look forward, and you should look forward to hopefully engaging in these discussions and RSVP for these sessions so that we can include you and your perspectives, because this is where I think the rubber meets the road and how we think about the changes we would make in these areas to do our work better. For our session today, we will follow a similar format to our last session, but we are focused today on a case study, a clinical case. So we'll hear first a clinical case, followed by a series of flash talks. There will be a panel discussion among the presenters. We'll then have a break and then have a second panel discussion that will begin with a commentary and end with a closing commentary. These days are long, these half days are long, so I want to encourage you to not only listen to our outstanding speakers at the start of the day, but also our outstanding speakers and panels after the break. We're really pleased to have two individuals join us for our second session. Professor Osagie Obasogie is a professor at Berkeley, the Haas Distinguished Chair and Professor of Bioethics at the University of California, Berkeley, a faculty member in the Joint Medical Program and in the School of Public Health at Berkeley. And Dr. Eliseo Perez-Stable is the director of the National Institutes of Minority Health and Health Disparities at the NIH, and of course, a former faculty member at UCSF, and we're really thrilled that he was able to come back to spend part of the day with us. I'm really grateful to Dr. Christine Dellendorf, who's Professor of Family and Community Medicine, who has been a partner in co-organizing this event and really is the architect for this particular session today. Some housekeeping, we have Q&A, and you are able to participate in Q&A and through the Q&A function on Zoom. We have used your questions in how we have prepped for this session, and will use them and feed them back to the moderators of these sessions. If there are questions that are unanswered, they will help us in planning for upcoming sessions. This QRS code can take you to our website, where we have a recording of today's session will be up there soon. You can see a recording of our first session. There's information about upcoming sessions. There's today's agenda. We don't have time to do long speaker bios because we want to get to the content of their work. So I'd encourage you to read more about our speakers. And they have all offered a library of resources. So there's an impressive library there as well. Again, just the details of our upcoming sessions. On next week, we will continue with our case studies on eGFR, glomerular filtration rate, and on polygenic risk scores. Those are the two cases we're studying next week. And then again, session 4 on April 28th, really going deep with our small group work in each of our domain areas. And so with that, we're going to move to the case presentation and flash talks. So I am really thrilled to have 3 outstanding colleagues of mine at UCSF have agreed to give these talks that will follow the case presentation. Dr. Valy Fontil is an assistant professor in the Department of Medicine in the Division of General Internal Medicine at San Francisco General Hospital. He is a hypertension researcher, a faculty member in the Center for Vulnerable Populations at UCSF. Dr. Michelle Albert is professor of medicine and professor of cardiology. She directs the Center for the Study of Adversity and Cardiovascular Disease, the Nurture Center. She is the Associate Dean of Admissions in the UCSF School of Medicine, and she is the incoming president of the American Heart Association. And Dr. Akinyemi Oni-Orisan is assistant professor of clinical pharmacy and bioengineering and therapeutical sciences in the UCSF School of Pharmacy. He is a faculty member in the Institute for Human Genetics and a pharmacogeneticist. And we're really pleased to have all three of these outstanding presenters give their perspectives on the case study. And we're going to begin with a video of the case.
In recent years, medical institutions across the country have started to acknowledge that medicine has a race problem. Study after study has shown that historically marginalized racial groups shoulder a disproportionate burden of disease, have worse health outcomes, and experience substandard treatment from the medical establishment. So, what is race? How does it impact health, and how does it inform our clinical management of patients? And how does our understanding of race impact health equity? As was discussed in the first session in the series, race is a social category, not a biological category. However, the fact that race is a social invention does not negate the reality that living in a racialized society has biological consequences for minoritized racial groups. We know, for example, there is a higher prevalence of hypertension and diabetes and a higher mortality rate from heart disease in Black Americans compared to white Americans. Since we have established that race is a poor proxy for genetics, these types of disparities are best explained by systemic racism and the resulting lived experiences of those categorized as belonging to a racial minority group. Environmental racism, discriminatory hiring practices, police violence, redlining, food insecurity, inadequate housing, to name a few, all disproportionately affect Black and brown communities and can have profound impacts on health. So, given all this, how is race currently used in medicine, and how should race be used in medicine going forward? Let's examine some of the ways that race currently impacts clinical care with a hypothetical patient encounter. Mr. Thomas is a 55-year-old man who presents to clinic to establish care. He has a history of hypertension and asthma and is not currently taking any medications aside from a rescue inhaler. His provider, Dr. Jones, talks to Mr. Thomas about his hypertension, and together they decide to start medication therapy. Dr. Jones consults the JNC8 guidelines for the best pharmacologic treatment options and shows Mr. Thomas the treatment algorithm.
As you can see, your best option would be a thiazide diuretic or a calcium channel blocker.
While Mr. Thomas thinks to himself, why does my race influence my treatment options? My mother is white and my father is Black. Does that change anything? What other aspects of my care are affected by my identity? I've had bad experiences with healthcare systems in the past, and I don't want to seem combative or ignorant, so I won't ask any questions. He says,
Okay.
Mr. Thomas is started on a thiazide and returns to clinic a few weeks later.
I'm glad to see that your blood pressure is better today. I'd like to talk some more about cardiovascular disease. Given your age, sex, race, cholesterol, and blood pressure, you have about a 13% risk of atherosclerotic cardiovascular disease, also called ASCVD, in the next 10 years. As you can see, Mr. Thomas, being Black significantly increases your risk of cardiovascular disease. In fact, putting in your race as Black gives you double the risk than if you were white.
Why is that, doctor?
Well, there are likely many contributing factors, but it probably boils down to genetics. Regardless, your risk is high enough that I'd like to start you on a statin.
While Mr. Thomas thinks to himself, being Black intrinsically makes me less healthy? Is my body fundamentally inferior? He says,
Okay.
Lastly, I'd like to discuss how well your asthma is being controlled with your current medications. Interestingly, some research shows that African Americans may respond differently to commonly used medications like inhaled corticosteroids and long-acting beta agonists. So this may require us to make some dosage adjustments to your medications.
You know, I had no idea my race had such a large impact on my health and treatment options. Luckily, my asthma has been really well controlled with my current medication, so I think I'd like to stick with that.
As we saw with Mr. Thomas, race is commonly and too often uncritically utilized in various aspects of medicine. And a patient's race can directly impact the diagnosis, treatment options, and overall quality of care a patient receives. As clinicians and scientists, we must constantly question when, how, and why race is employed. Some questions to consider are, in what circumstances is it appropriate to utilize race in clinical medicine? Should it be used at all? How might the use of race in various clinical scenarios perpetuate or alleviate inequity? And how can we use race in a way that reflects an understanding that patients' experiences existing in a racialized society, not inherent racial susceptibilities, are what put them at risk for poor health outcomes? In considering these questions, we can understand how to use race in a way that is thoughtful, intentional, and critical, with the goals of better understanding and addressing the root causes of health disparities and ultimately improving the care our patients receive.
Great, thank you. I'm going to invite Dr. Fontil to begin the talk. One of the points raised in this case is about our current algorithms for prescribing and treating blood pressure, high blood pressure, that have a suggestion that different medications, usually not using ACE inhibitors, should be what how one should approach patients who are Black. Dr. Fontil.
Thank you, Kirsten. Again, my name is Valy Fontil, and I do research on hypertension. I'm really honored to be here and be part of this important conversation. Let me just share. Should I share my screen now?
Oh yeah, if you could share your slides.
Share the right screen. Okay, as I mentioned, what I'd like to do first is to just clarify what we saw in the video as the guideline recommendations for hypertension and with respect to race. Essentially, in the video, you saw that the guideline really said that for a Black person or African American, that you should start therapy with either a thiazide diuretic or a calcium channel blocker. And what that really is saying, what the guidelines in effect are saying, is really to avoid an ACE inhibitor or an angiotensin receptor blocker as the initial therapy for blood pressure treatment, and specifically in Black patients. So what I'd like to do with this introductory talk is really talk about, is this race-based sort of consideration for treatment of hypertension, are these guidelines really warranted? And in thinking about this, I wanted to approach this and share with you simply just my thought process into answering this question. What won't be included in this talk is a thorough review of the guidelines or in-depth critical review of the evidence. But I hope by sharing with you the rationale, it can start to trigger a conversation and questions that will help us bring light to this topic. So are these guidelines really warranted, is the question. And in answering this, I asked myself essentially 5 questions. What is the rationale that I think is important to understanding to answering any of these types of questions? And the first one is, what is the rationale and intention behind these? What's the underlying evidence? What's the quality of the underlying evidence? Are these specific race-based combinations, recommendations helpful? Is there a better alternative? And what is the potential harm of having this guideline? So the rationale that underlies these recommendations is essentially that we know that from sort of epidemiologic studies that Blacks have a higher prevalence of hypertension and lower rates of blood pressure control, and that there is evidence in the literature to suggest that Black patients tend to have a lower response to ACE inhibitors and angiotensin receptor blockers. So based on this evidence, many guidelines, at least more than 6 guidelines dating back at least to 2010, have sort of suggested that ACE inhibitors and ARBs should not be routinely initiated as a monotherapy. I would also point out that it's really talking about initiating it as a monotherapy, but all the guidelines always point out that it's okay to use them in combination with other drugs, regardless of race. So what's kind of the state of the underlying evidence behind this? One is that what we mentioned before is ACE inhibitor monotherapy is associated with higher blood pressure in Blacks. The biggest criticism of the evidence is that there isn't a, sort of preset RCTs that had a direct comparison to study this question. But there has been multiple post-hoc analysis, pre-specified post-hoc analyses, cohort studies, and some even comparative effectiveness studies in the real world practice, in real world, to suggest that this association is true, that in fact, when Black patients on monotherapy with ACE inhibitor tend to have higher blood pressures when compared to whites. There's been a meta-analysis that shows this about a 4.6 millimeters of mercury difference. And a recent systematic review has also confirmed this sort of racial difference in blood pressure response on monotherapy with ACE inhibitors or angiotensin receptor blockers. The other rationale behind this is that low renin hypertension is the underlying mechanism for this difference that we see in medication response. The idea being, when a low renin state is associated with more resistant to ACE inhibitors and angiotensin receptor blockers. Be happy to answer questions on this mechanism, but that is what there's been multiple studies that have looked at the average renin by race and have shown that Blacks tend to have a lower renin levels, and that could explain this difference we see in ACE inhibitor efficacy in different races. So what are the limitations and questions about the evidence? For one, there's this question of racial admixture in different subgroups within Black populations. I think that's a significant limitation because the question is, well, as the person asked in the video, the question is, what about people of mixed race? Do we see these associations in terms of blood pressure response? And the literature, in my view, does not really elucidate this. And then there's also the question of subgroups within the Black populations. It's frankly, in many ways, even geographic variation may not really sort of fit this overall difference that we see. And so there's not enough, there's more nuance there that's understudied in the literature. The second limitation is that, as we've discussed before, there's more heterogeneity within racial groups than across racial groups. And that's true for both response to blood pressure medications and in terms of the underlying mechanism of having low renin. So for example, the mean renin levels tend to be lower in Black patients, but there's significant overlap when you look at the distribution of renin in the Black population compared to the white population. The other thing that the recommendations miss is that there are other factors associated with low renin levels, including age, including sort of salt content in diets, including volume status and other interactions that really sort of makes you wonder why was race singled out as one of as opposed to some of these other factors that are associated with lower response to ACE inhibitor therapy. The next thing is what are the underlying reasons for the differences are not completely understood. We know that there are interactions between genes and sort of environment. There's interaction. There's just, as I mentioned before, diet by itself can contribute to these differences. The other thing is the concept of allostatic load, just in terms of just experience racism, experience psychological stress, affects the physiology in a way that could confound or at least contribute to this relationship. So in conclusion, I would say that race is most likely is indeed a poor predictor of renin level, if you think about it, and is likely also a poor predictor of medication response with respect to ACE inhibitors and angiotensin receptor blockers. Just to illustrate this point, in one study that was looking at quinapril that compared the response to quinapril, which is an ACE inhibitor, between white participants and African-American participants, you can see here that you see the difference. So the median response in Blacks is 10 millimeters of mercury, and the median response for whites is 16. And so you see this difference in sort of the response. But if you look at the actual graph, one, you see that the distribution is wide in both groups, in each group. There's very wide distribution in whites and very wide distribution in African Americans. And significant overlap if you were to juxtapose or these two curves together. And so just to drive this point further, what this says is that there are a lot of white patients and white participants who don't respond that well to ACE inhibitors, and there are a lot of Black participants who did get good response to ACE inhibitors. And so there's a significant overlap there that's not really, that kind of get lost in the recommendation and interpretation of these. So the next question is race. Are these recommendations helpful? So is it helpful in reducing disparities? I've not seen much evidence that it is. You know, these recommendations have been around. There's some evidence that doctors are actually following these guidelines, and we don't see a trend in reduction in disparities as a result of this. And I'm not surprised by this, because if you wanted to reduce disparities, focusing on which medication to use is probably the wrong focus. In clinical practice, it's not super helpful because it's really difficult to implement in practice. How does a doctor actually determine a patient's race? How does that doctor communicate that treatment plan to the patients? I think introduces serious problems and concerns in the real world. What is the potential harm? Well, for one, the potential harm that I like to highlight is that this could lead to suboptimal therapy, frankly, in non-Black patients as much as it would be in Black patients. So for one, one of the most immediate potential harm is that it could lead to inappropriate use of ACE inhibitor monotherapy in non-Black patients. There's also a risk that you can inappropriately avoid ACE inhibitor in Black patients who actually need it. For example, patients with certain kidney disease, specifically proteinuria, you know, a doctor may make the mistake in thinking, well, we can't use ACE inhibitor in Blacks and therefore avoid that. It would be a mistake, but these guidelines make it more likely that a physician would make that mistake. It may reinforce a cognitive bias based on skin color, and it potentially detracts from more appropriate priorities like rapid escalation of treatments. Most patients in general, and Black patients in particular, will require 2 or more medications And so the focus and the bigger barrier is sort of the timidity to escalate treatment in these patients. And also it detracts from the real important priority of policy interventions that addresses social determinants such as food access, transportation, and also mental health services. I would also point out that there is a better alternative to focusing on this. I think the evidence would lead us to focus more on ACE inhibitors and ARBs and not really race. The truth of the matter is that ACE inhibitor monotherapy is just probably a poor choice for many patients, and that we should consider avoiding ACE inhibitor monotherapy in most patients who don't have kidney disease or heart disease. And we should think about ACE inhibitors and ARBs generally best as used in combination with other drugs. So in the end, I would say that these guidelines are not warranted, and that it's guidelines to avoid monotherapy with ACE inhibitor and ARBs in Black patients are frankly unnecessary and potentially misguided and harmful.
Thank you very much, Dr. Fontil. I'm going to turn it over to Dr. Albert to comment on the case study using race in our 10-year predicted probability of a cardiovascular event.
Seeking to share my screen currently. Can you hear me?
Yes, we see your slides.
Thank you. Hello, everyone. The goal of my presentation today is to contextualize the 13% ASCVD 10-year risk in our patient, and also to hopefully provide a lens into the future for risk assessment for cardiovascular disease and stroke. So I wanted to start with the principles of ASCVD risk assessment. It is important to realize that risk assessment offers a doorway and is not an end-all be-all, and focuses on absolute risk, that is prognosis, versus relative risk, which is dependent on the reference incident rate of a condition in the population. It seeks to identify persons at higher risk of getting atherosclerotic disease, and those who might receive enhanced benefit from therapies such as statin therapy, aspirin therapy, and blood pressure control, and also focusing on where the number needed to treat to achieve a particular risk reduction is low. It starts a clinician-patient discussion, such as how intensive my preventive therapy should be. I also think that it's really important as we think of the ASCVD risk score to think of the history of it. And on this slide, you can see that there are 9 risk scores that were put forward in the United States starting in 1998 to our present time. Starting with the Framingham risk score. It is important to realize that the Framingham through the Euro score all included persons of European descent or white men and women, and no individuals of color or no Black persons. So in the development of the pool cohort equation, ASCVD risk score, the focus was to make sure that certainly that it represented a population of certainly whites and Blacks, And this was convened a working group at the NHLBI and included 4 multi-ethnic cohorts, including the atherosclerosis risk in communities, the cardiovascular health study, Cardia, and the Framingham Health Study. So that is how our pool cohort equation was derived from a population perspective. And then there's a contemporary cohort validation utilizing the regards cohort. I was honored to be one of the writing group members of the most recent 2019 ACCHA guideline for primary prevention of cardiovascular disease, which recommended use of the pool cohort equations as the first level of assessing cardiovascular risk. As we think about cardiovascular risk assessment, the PCE is validated in non-Hispanic whites and non-Hispanic Black persons living in the United States. The guidelines also now have clear language about limitations of the PCE. The PCE may overestimate or underestimate risk. As you can see in bold on the right side of the slide, the things here, age through hypertension, are included in the risk score. However, other very important factors that impact risk are not. And you see on the left-hand side of the right-hand side of the slide here, including therapies, including pregnancy-related CVD, socioeconomic factors, mental stress, depression, etc. So where might the PCE overestimate risk? We know that the PCE overestimates risk in relatively healthy individuals. So these are data from the Kaiser Health showing in red that the expected rate of CVD is much higher than the observed rate in a relatively healthy cohort, that is folks who did not have diabetes, did not have high cholesterol levels, et cetera. And then in the MESA study, the PCE overestimated risk in all racial and ethnic groups. The highest overestimate was in Chinese individuals and lowest in white women and Hispanic men. PCE also underestimates risk in those persons with inflammatory conditions, such as HIV, rheumatoid arthritis. If we take into account a social determinants of health, such as neighborhood SES, PCE also underestimates risk. On the right-hand side of the slide, the dotted line shows the predicted risk. And in the least affluent neighborhoods in this study, published in the Annals of Internal Medicine 2017, you can see that at every risk level, that the observed risk of persons living in the lowest neighborhood SES was much higher than what the PCE predicted, versus those in the most affluent neighborhoods, the risk prediction was spot on the expected line, the observed risk. So in the 2019 ACCHA guidelines, there are several general recommendations for care. One, team-based care, shared decision-making, and for the first time, the guidelines included social determinants of health should be used to inform optimal implementation of treatment recommendations. I should note that it didn't say anything about social determinants of health incorporated in predicting risk. Social determinants of health are important in risk assessment, and this was recognized by the Guideline Writing Committee, because we know that socioeconomic disadvantages are not captured by CVD risk equations. Indeed, there was recommendation that the Medicare-Medicaid develop screening tool to assess social determinants of health, including housing instability, food insecurity, transportation difficulties, utility assistant needs, and interpersonal safety be considered as we look towards management of our patients and risk assessment. There were example considerations for addressing social determinants to help prevent ASCVD. And so, for example, in cardiovascular risk assessment, the recommendation was made to evaluate psychosocial stressors, pay attention to health literacy as one attempts to implement management and therapies for patients, pay attention to economic factors, neighborhood environment, when one thinks about exercise and physical activity, for example. It is really critical to understand that social determinants are linked to adversity. The definition of adversity from the Merriam-Webster dictionary is that it is a state of serious or persistent difficulty or calamity or misfortune that affects one's ability to achieve various goals, outcomes, and well-being and happiness. Certainly in our case for Mr. Thomas, there was no discussion with Dr. Jones about underlying factors that might impact his preventive care. This is an equation that I came up with to think about how does adversity translate into clinical medicine. If we think about outcomes, in this case, CVD outcome plus well-being, is the balance of adversity plus resilience over wealth. And wealth can be joy, it can be money, it can be however one defines it. As we think about this issue of race and racism, I would like to argue that the biology of racism-related adversity gets baked into our brain, resulting in various biological processes, upregulation of inflammation, glucocorticoids, or flight or fright response, resulting in biological short-circuiting or allostatic load, resulting in cardiovascular disease, metabolic perturbations such as diabetes, and accelerated aging, all influenced by behavior as well as genetics and epigenetics. Certainly we know from the cardiovascular perspective that the discrimination iceberg is really important. We know the discrimination can be covert or symbolic, which is about 2/3 of our discrimination. And you'll hear some stuff about structural discrimination, which is key as we think about risk prediction and healthcare. And there's a readily observable or overt discrimination. We know that everyday discrimination is possibly associated with surrogate biomarkers of cardiovascular disease risk, including coronary artery calcification, high levels of C-reactive protein, hypertension, as well as one study showing mortality, visceral fat, poor sleep, and cognitive impairment. So getting back to our patient, what factors should influence our preventive strategies? Can we trust the PCE, or do we need to do more? Certainly, Mr. Thomas has agreed to take a statin, but it can be argued he should be reluctant to take the medication, based on what we know with regards to medical mistrust for therapies, as well as the use of race in medicine. Certainly, from a practical perspective, what we have right now is assessment through PCE, thinking of 30-year ASCVD risk, adding risk-enhancing factors such as metabolic syndrome, chronic kidney disease, and adding coronary calcium to our risk assessment toolkit in order to determine whether or not Mr. Thomas, what therapies and advice should we give Mr. Thomas. So as it pertains to the risk assessment and the race comparison, you already heard that for Mr. Thomas, his 10-year risk is twice that of a white male. But I want to remind us about the intersectionalities that exist as well. For females, if Mr. Thomas was a woman, a Black woman, her 10-year risk would be 7%. That is also, based on the PCE, two times higher than a white female. However, as you heard, this biology of adversity or racism-related adversity is what probably determines this risk. And the question we have to ask ourselves, if we were to add the social determinants of health into our risk equation instead of race, how would it affect these numbers? Nonetheless, what we're left with for therapy for Mr. T is that his risk assessment falls in the middle range of our risk. So we would recommend lifestyle, blood pressure control, and statin. And we need to ask ourselves, is his risk enhanced from inflammation? He does have asthma, which is an inflammatory condition, and you'll hear more about that in the next flash talk. And it's important to meet patients where they are. That is, understanding what their preferences and priorities are. So to conclude, I would say that ASCVD risk assessment is a bridge over troubled waters. The points here are that the guidelines are evolving related to the ASCVD guidelines, and the recognition that social determinants of health, especially underscored by racism, categorizes persons in a manner that has real biological consequences, and that equity depends on understanding and capturing social risk in assessment and management. Thank you so much for inviting me to be a part of this discussion.
Thank you, Dr. Albert. I'm going to turn it over now to Dr. Oni-Orisan and to talk us through some of the aspects of this case related to pharmacogenetics.
All right, can everyone hear me okay? And see my slides?
Yes.
All right, so my name is Akinyemi Oni-Orisan, and I'll be talking about pharmacogenetics, race, ethnicity, and genetic ancestry. So as you saw in the case, the patient was told by their clinician that they respond differently to asthma medications based on their race. The patient was also eligible for statin therapy based on their race, and I will be focusing on that treatment as opposed to asthma medications. So the question here is, how can we optimize statin therapy to maximize benefit and minimize risk? So we first turn to, just like my predecessors, we turn to the guidelines. So the 2018 ACCHA cholesterol guidelines. So the guidelines recommend moderate or high intensity statin therapy, depending on the clinical factors of baseline ASCVD risk. And this really pertains to efficacy of the therapy. However, statins also cause side effects, most commonly muscle toxicity. And so this warrants further optimization of the therapy. So this is where pharmacogenetics comes in. The previous guidelines, the 2018 ACCHA guidelines didn't include any pharmacogenetic, really didn't have any pharmacogenetic experts on the writing group, and so that wasn't really addressed. However, the Clinical Pharmacogenomics Implementation Consortium, based on substantial evidence, has recommendations on how we can guide statin prescribing based on genetic background. And they recommend, with a strong level of evidence, that individuals with intermediate or low function in a gene called SLCL1B1 should be prescribed lower simvastatin dose or consider alternate statin therapy due to increased risk of statin-induced myopathy. 16-fold increased risk in individuals with this CC genotype, a really large effect size. So pharmacogenetics is the effects of genetic variants on how someone responds to a drug, whether that be efficacy, safety, how the body processes the drug. And so how exactly does this occur? So the genetic variant can impact how the drug is absorbed, how the drug is distributed throughout the body, how the drug is metabolized, how the drug is excreted, pharmacokinetics, or the genetic variant can affect how the drug binds to a receptor at its target site, pharmacodynamics. So one of the most important concepts in pharmacogenetics that we try to teach is that this is only one piece of the puzzle. There are many other factors which impact how someone responds to a drug. So in addition to genetic variation, adherence plays a role, kidney function or other organ function, concomitant medications, even the microbiome, even gut bacteria can impact how someone responds to therapy. And this is by no means an all-inclusive list. So in terms of statin-induced myopathy, let's revisit the ACCHA guidelines and see what they list in terms of the predisposing factors. So they list age, female sex, low body mass index, interacting drugs, comorbidities, and most important to this session, they list Asian ancestry is found to have an association. So in addition, the FDA actually advises that rosuvastatin be initiated at a lower dose in Asian patients. And in Japan, there are no statins that are approved at the highest doses that are approved in the United States. So let's investigate that a little bit further. So in this study, they had about 35 individuals in each of these 4 groups, and they all were given a single dose of rosuvastatin. And then they looked at the pharmacokinetics, or how the drug levels over time of rosuvastatin. All of these individuals were residents of Singapore, so they're all in the same general location. And they ultimately found about a double of rosuvastatin plasma exposure in these populations compared to white. So they actually tried to look for some of the contributing factors, and they actually did not find any major factors that contributed. They measured gross dietary intake. They did look at the SLCO1B1 genotype. They were all in the same, they all live in Singapore, as I mentioned. They also looked at body weight. So it's still unknown whether genetic factors beyond SLCO1B1 or social determinants, non-genetic factors, are contribute to these differences that they observed. So there are several different statin types, and all the statin types have different biochemical properties. And this influences how the different types are metabolized and how they are distributed throughout the body. And this is further complicated by the findings that the frequencies of the polymorphisms in these various genes within these pathways are vary by population. And this is just an example in SLCO1B1. Of course, also social determinants, as I mentioned, play a huge role here. And so these all have potential clinical significance. However, there is a lot of gaps in the literature. So ultimately, we need more data so that, and with more, social determinants, with more, genetic variants, so that as covariates, so that we can really identify what are the key contributors to these disparities. And if we can fully characterize the genetic factors and the non-genetic factors that contribute, ultimately, race, ethnicity, ancestry is really not necessary if we can determine the functional variance and the key factors that contribute to this response. But importantly, we need to do this in broad populations. So, this, discussion about the need for inclusion of broad populations perfectly segues into a paper that myself and colleagues recently published that largely talks about inclusion. I wanted to just briefly touch on some of the main themes of the paper. So this was really from a perspective from 5 Black geneticists, which we thought was a viewpoint that was largely missing in the literature concerning this topic. There actually might only be, no more than 10 to 15 Black population geneticists in the country, really. So we talked about racism. We discussed our own experiences as underrepresented minorities in academia and some of the shared struggles that we experienced. We also talked about COVID-19 disparities in vulnerable communities, and these are all under the umbrella of structural racism. We talked about some of the consequences of ignoring race in medicine, and we also delved into the importance of genetic ancestry to ensure that we can capture all of human genetic diversity. We did discuss the utility of race ethnicity and how it can help to advance scientific discovery. Really as it pertains to ensuring that that genetic and clinical research is inclusive and that the results benefit everyone. We also talked about the need for diversity among our scientists and clinicians, as well as the benefits of crosstalk between disciplines. If these themes resonate with you, for the most part, I would say we're on the same team. So just to summarize, both genetic and non-genetic factors contribute to drug response. Pharmacogenetics, do consider non-genetic factors. We do consider adherence. Adherence and pharmacogenetics can coexist. And it's really important that we consider all factors in order to really determine the causative effects of some of these genetic variants. Genetic variation, not race, is the foundation of pharmacogenetics. And race-based medicine is not the foundation of pharmacogenetics. And finally, implementation of pharmacogenetics in individuals has implications for addressing health disparities at the population level. Thank you.
Thank you very much. I'm going to invite all of the other speakers to join us for a discussion. Thank you for those really outstanding talks. Wonderful, wonderful. We've had some great questions from the audience, and what I would like, so here's the way I heard your talks. That I like the way that you deconstructed the way we got here and the challenges of using race in our factors. And I'll focus first on maybe on Dr. Fontil and Dr. Albert. I guess my question is, both of you have urged us to consider social determinants. I'm going to guess, Valy, when you talk about the low renin levels, that there's probably some evidence perhaps, and maybe you can comment on this, whether social determinants might actually be a grouping that's associated with lower renin levels. In your view, if we measured more social determinants, would we still have race in the way we think about either risk assessment or prescribing, because there is a biology of racism? Or do you think that the broader constructs of social determinants then replaces what we have with race in our calculators?
Thanks, Kirsten. The short answer for this very tough question, the short answer is, I don't know. The short answer is, I think your question is a good study question. I would love to research that. I do think so. For example, to comment on the first part of your question about renin and how social determinants might contribute to that. It's true. I think that when you look at the levels in renin activity and renin concentration in Black patients, it's low renin but high pre-renin. So it's not something. Which tends to indicate that it's at least sort of volume status, sort of sodium retention and volume expansion is probably the main contributing factor to this low renin. And so clearly, just sort of logically speaking, if you think about allostatic load or psychosocial stress, one of the main things is cortisol level, which would increase sodium retention and volume expansion, which would then cause a low renin. So it definitely stands to reason that these types of social determinants and psychosocial stress would contribute to these differences in biomarker concentrations that we see here. I should also mention that there are genetic studies about that does link some polymorphisms to renin levels into the RAS, renin, angiotensin, aldosterone system. It's kind of beyond the scope of my scope of competence. I think there's some complexities in some of these studies I'm not sure are really good. but they do exist. And some of them, and some of these polymorphisms are sort of more common in Africa or people with African ancestry. The problem with that, though, is that there's wide variety, even just based on geographic variation in Africa itself. So these genes are not sort of just, they vary by geographic location in Africa. And there are also other genetic polymorphisms that exist in other races that is associated with renin levels and RAS system. And so so that's why I think the question is somewhat still open, in that if you did adjust for and account for the social determinants, would there still be a remnant sort of genetic related effect or difference based on genetic variation? Maybe, but would it track by race? I don't know. If I had to hypothesize, I might say maybe not, but I don't know.
Dr. Albert, what do you think? You talked a lot about racism related biology. We sometimes, there are ways in which we could imagine these tracking that might suggest or imply innate genetic factors, and there are ways in which you have talked about the biology of racism. How would you think? Is there still a role, if we could measure these things more precisely, is there a role for self-identified race?
So thanks for that question, Kirsten. I have two approaches to that. The first is that we know that self-identified race does capture factors that are related to racism, right? Which is why I presented that model of racism-derived stress and the resultant diseases that can occur from them. I think my approach to the answer to the question about the social determinants and whether or not they would replace race, I think you have to think about it in the structure of surrogate biomarkers, because what we're thinking of is social determinants as a surrogate biomarker for an endpoint. And there are three things that you have to think about in that context, and let's think about social determinants and race in this. You must have analytic validation. You must have, which relates to reliability of the marker. You must have quantification, which relates to the strength of the marker and the strength that marker is associated along the pathway of the disease that you're measuring. And that might vary depending, the influence of the marker may vary where you are in stage of a disease process. And then you also have to think about utilization, and that is the context in which the marker is useful. So let's think about race. If you think of those three things, race doesn't work for validation, it doesn't work for quantification, it doesn't work for utilization. So as a surrogate biomarker, not, okay? As we think about the social determinants of health, we need work along these lines. I would suggest that, the validation part of it may be a little bit dicey. The quantification part is possible. And the utilization part is going to be a little bit dicey as well. And so the bottom line is that we need research using, broad population samples that are clinical trials, actually, in addition to our epi research that look at outcomes that incorporate social determinants of health. Sorry for the long answer, but it is, intended to be a structural answer.
Excellent, thank you. Dr. Oni-Orisan, you've laid out nicely, and we all know that there are differences in response to therapeutics. Help me understand where we are in our knowledge spectrum. Is pharmacogenomics is it ready for clinical prime time? And what are the dangers of understanding differences by ancestry? Is that a step along the way to actually understanding the basis for the differential drug response? And one of the questions from the audience is, if in our highly admixed populations, how do I understand how ancestry that you're studying and helping to elucidate these differential drug response, how do I apply that to an individual patient who comes with multiple types of ancestry?
Well, I first wanted to stress that one of the key points of my slides was that genetic variation, the actual genetic, the genetic variant itself is the foundation of pharmacogenetics and how that impacts drug response. So there's nothing in any pharmacogenomic guidelines about optimizing treatment based on anyone's race or ancestry. So I wanted to start with that. However, we do have, there is utility that has Dr. Albert alluded to, of research in broad populations that capture genetic diversity with different ancestries, and race has a utility in terms of capturing that because many individuals don't know their ancestry. So in terms of admixed individual who I'm seeing as a pharmacologist providing pharmaceutical care and recommending optimized therapy for that individual, I wouldn't use any aspect of their ancestry in guiding treatment. However, I would make sure that the literature has individuals that include their ancestry, because in order to to ensure that they are adequately represented in the studies that ultimately I will use to guide treatment. So in terms of your question about prime time, so pharmacogenetics it depends, it really depends. I mean, there are specific disease states, specific gene drugs that have adequate evidence, that have analytical validity, clinical validity, and clinical utility. I mean, they've shown it in randomized controlled trials that it actually reduces costs, it improves safety, and it improves efficacy. CYP2C19 with clopidogrel is an example of a therapy or of a genetic test that has been shown to reduce the risk of bleeding and to reduce the risk of poor response to clopidogrel treatment in some individuals that have loss of function variants. So that was a long-winded answer to your questions.
To push a little bit more, though, you are saying that if I understand what you're saying, that ancestry now is a tool that might help us in discovering the specific variants that would explain differential response, but they would not be how you would implement them clinically.
Exactly.
Okay.
So we know that the variation in some of the genetic variants differ by population. So we need to make sure we have broad populations in our research.
But we do have, when you showed in the statin studies, I think we do have a suggestion that we would choose a different statin based on someone's Asian ancestry.
I didn't show
Is that true or not?
So that was recommended by the ACCHA guidelines based on the data that I showed with the statin. So, but as I mentioned, they didn't actually determine any of the factors that were contributing to that response. So what I was saying was that more research is needed.
Yeah. So I'd love each of you to think about this because I'm hearing we need more data in how we think about the care for an individual patient, and we need more data in our research across these multiple domains. How do you think? Go back to the case. Each of you are clinicians. Each of you practice clinically. What are the dangers of communicating? You're the clinician communicating with Mr. I'm forgetting his name in this case study. But the patient, Mr. Thomas there, who, as you pick up the calculator, says black race differential thing. You chose a different medication. You've suggested that maybe he's going to respond differently. How do we communicate that to patients if you think there's some utility in still having that these guidelines the way they are now?
I think, Kirsten, it's important, and I had on that slide, sort of how do we, the risks based on the current PCE, based on male, female, black, white. Certainly, there are not similar data for Hispanics or Asians, at persons at this juncture. I think that it is important to tell our patients, what we know and what we don't know, right? And that, sort of medicine, just like anything else, is an evolution over time. We developed antibiotics, after a while of having infections and studying infections. So I think we just have to, sort of meet our patients where they are, tell them what we know and what we don't know, tell them, sort of what our the current recommendations are and the current potential harms are related to instrumenting a particular therapy. And that is why this needs to be a shared decision-making between Mr. Thomas and Dr. Jones, or Mr. Thomas and Dr. Albert. And I think that fundamentally it's developing that trust, understanding, who the person is, where they are, what are the influences related, like, where do they live? What are their current stressors? And bring that into our clinical therapeutic relationship and ultimately our management. And it is an evolution that we are in at this point in time.
Right, Dr. Fontil?
I struggle with the communication when it comes to the ASCVD risk. I don't think I've ever communicated that to my patients, frankly, as an individual provider. I think it's harder. I think it's harder with the ASCVD risk because it's a risk score, and then you'd have to tell them why their risk is higher. And I don't know how many clinicians are thinking to tell the patients that, other than just calculating the risk and deciding whether they need a statin or not. And to that, I do think that it's important to really make that, since risk scores is a predictive model, then the model is really important that the model continue to improve, to have enough discrimination and to be valid enough, and not use it inappropriate or an imperfect proxy. And so I think that is one of the common thing that I see with ASCVD risk, and what I'm seeing with the evidence in hypertension, is that it's really important to flesh out these risk models. So it's like you might see a difference by race, but then what else, understanding what else goes into that. In hypertension, I think it's becoming, I've kind of come to the conclusion that with the ACE inhibitor is, as I mentioned, it's really about thinking about when is, thinking about how we use ACE inhibitors and when they are appropriate and inappropriate. I've kind of come to the conclusion that we don't need to consider race that much. We know enough that it shouldn't be based on race. So I don't see that as a conversation that it's not as difficult to have that conversation, because I won't bring race into making that decision. Essentially, I'm not going to start an ACE inhibitor monotherapy in most patients, regardless of their race.
Great. Dr. Oni-Orisan?
I agree with, I agree with Dr. Albert, Dr. Fontil. I guess the one thing I would add in terms of communicating to patients, it actually helps to have a diverse, body of clinicians and scientists to help to communicate with different populations. It helps to have cultural competency. And so we need to start thinking about how we talk about different fields, so that, in terms of helping to ensure that we have, minority trainees and students going into different fields and both as scientists in research and clinicians in practice. I don't know too many other Black scientists that do pharmacogenetics, honestly. There's been a lot of papers and talks that kind of downplayed, some of the importance of fields such as pharmacogenetics. And when you do it in the context of race, it makes it a barrier to get some of diverse scientists that want to enter the field. I think Dr. Kemi Dahl wrote a paper in New England about subspecialties, and it was called the rarest of the rare, and it was about how it's very difficult to get minorities in some of these subspecialties. So I think that that's really important in communication.
Excellent, excellent. Well, thank you so much for your outstanding talks and perspectives. And I think you have given us all a lot to think about. There's some outstanding questions in the chat, and so I think they will help us to continue the discussion in the subsequent panels. But really appreciate you laying out many of the issues on a complex topic. Thank you so much.
Thank you.
Thank you for having us.
So I think we are going to move to a short break, and I know there's a slide coming up saying when we will resume. So we'll resume at 9:58. And as you're taking your break, I'd urge you to consider what you might do differently in your work based on what you've heard today from our speakers, what questions still remain for you. Hopefully we'll continue to explore those as this session continues, and come back and join us at 9:58. Thanks so much. think we are welcoming everyone back from the break. So we're going to move now into a commentary and responder panel. Next slide. So I'm pleased to welcome my colleague, Professor Obasogie from the University of California, Berkeley, who has written extensively on the topic of race and medicine. And following his commentary, he will moderate a panel of my colleagues at UCSF, Dr. Denise Connor in the Department of Medicine, who's the leader of our anti-oppression curriculum in the UCSF School of Medicine, Dr. Tung Nguyen, a professor of medicine at UCSF, who is one of our leaders in diversifying our clinical studies, Dr. Neeta Thakur, who is professor of medicine and a pulmonologist who studies factors both related to environmental, social, and genetic factors related to differential drug response and asthma response, and Dr. Teresa Villela, who is the vice chair of the Department of Family and Community Medicine. So I will first turn it over to Professor Obasogie.
Thank you so much for that introduction. So over the past several months, I've been pleasantly surprised by the number of medical schools and schools of public health that have made clear statements in support of racial minorities in light of the devastating acts of violence we've seen against communities of color. A number of these schools have declared themselves to be anti-racist institutions, or at the very least, they have stated an aspiration to include anti-racism in their curriculum and activities. So this has been an important gesture, but it's also important to ask whether this is enough. Anti-racism as an ideal focuses on the individual. It seeks individual training and transformation in how people view the world and how they treat others. To be clear, this is good and necessary work. But as we look at the problem of race in medicine, addressing individual pathologies is not enough. Race is a structural problem in how medicine is organized. So this structural problem is what allows clinicians to assume that Black people feel less pain and therefore are in less need of pain management options. It's a structural problem that can lead JAMA to declare in a tweet that, quote, no physician is racist, and to do so while pretending to explore structural racism itself. It's also a structural problem that medical schools are producing so few Black and Latinx physicians. Race and racism have been foundational to how medicine has operated for decades. And this new emphasis on individual training on anti-racism often misses this structural dynamic. Put differently, centering the conversation on training individuals to be anti-racist without addressing broader institutional dynamics of race and racism in medicine is not a substantive or meaningful engagement with the problem, and it risks simply turning into another form of public relations. So as we transition to the next panel, I would like for us to think about ways for clinicians to not only embrace anti-racism in their work, but to develop interventions that can change the way that we do medicine so that we can serve and improve the health of diverse communities. So today we have 4 esteemed panelists who can help us do this. So first we have Denise Connor, who's an associate clinical professor at UCSF. We have Tung Nguyen, who's a Stephen J. McPhee Endowed Chair in General Internal Medicine at UCSF. We have Neeta Thakur, who is an assistant adjunct professor at UCSF. And we have Teresa Villela, who is a professor of family and community medicine. And I want to start off by asking each of the panelists to talk for a few minutes on their reflections on the previous panel and to provide some of their thoughts. And then we'll have some individual questions for the panelists and then open up for the open things up to the audience. So first, Denise, do you want to share your initial thoughts or reactions to the first panel discussion?
Thank you so much. And thank you for your comments and framing of this discussion. I'm very honored to be here with all of you. What I actually wanted to address was something you were just discussing, which was the structural changes that are needed. And I wanted to make an argument that medical education is a lever for structural change in this realm. and a really important one, certainly not the only one. But when I was listening to the initial case of Mr. Thomas, we heard his voice silenced throughout that encounter. He had many moments where he wanted to ask questions, where he had concerns, and we heard his internal monologue sort of silencing that voice. And when I see that, what I think about is something called health-related stereotype threat. This is something that one of your colleagues actually at Berkeley, Dr. Tina Sachs, has written about beautifully in a book called Invisible Visits. And the idea here is that patients are well aware of the racist history of medicine. They come into the clinical encounter aware of these stereotypes, and many patients spend a lot of emotional and cognitive energy trying to combat those stereotypes. And sometimes that means being silent and not asking questions when they actually have questions, as we saw in this video. And the reason I bring this up and how this relates to medical education is that we have a medical education system that is rigidly hierarchical and that does not necessarily always encourage students to ask critical questions and to be treated as sort of co-learners, especially in the realm of race and racism in medicine. And when they arrive, when they've kind of gone through this training that is very hierarchical and arrive in the clinical setting, they're not really ready to flatten hierarchy in the clinical setting, which is what is needed to let patients break out of the sort of experience of stereotype threat. Patients need to be able to feel centered in the clinical encounter and to feel their voices lifted up. And if we want students to come out of training and be ready to do that, they need to have experienced that throughout their education. So I would say that bringing an anti-oppressive lens to pedagogy and the approach that we take for medical education and practicing those principles throughout education will result in students who are ready to be clinicians who can actually enact that kind of approach in the clinical setting as well. So I think there's a sort of a structural change to how we teach that has a direct impact, hopefully, on our patients in the future.
Great. Thank you so much. Tung, do you want to share some of your thoughts?
Yes, thank you. That was a pretty amazing set of presentations. And in particular, I was very appreciative of the complexities and the nuances, and particularly the humility that we just don't know enough. We're trying to address, I think the idea is that we're in the middle of a transition time. And the question is, what are the decisions that we're making during transitional period that's going to help us learn more and come up with better measures or better ways of doing things. And we have to acknowledge this, because I think sometimes one of my favorite saying is that there are no simple solutions to complex problems. And the more simplified we try to make it, the worse we make the problem. And that's, I think, speaks to your idea about structural issues. I think, again, biomedicine has always been very reductionistic. I mean, that's the way we do our research. We like to narrow everything down to the single isolatable factor. And then we never, ever get back to opening it up again to living in a community and in society. And that, I think, is a fundamental biomedical problem. And the more we focus on this conversation between race and biology, we do learn a lot, but then I fear that we never get back to opening it up to, like, how does this impact patients? How does this impact society? How does this impact disparities and equity? And so I'm glad that we're engaging in this conversation. I don't have an answer, but thanks for having me on.
Great, thank you. Neeta, would you like to share your thoughts on the first panel?
Yeah, thank you for having me here today. It's been a really great discussion this morning. I wanted to really focus in on a couple of points that were brought up by the case, but then also importantly by the panelists. And I think the first point was that it's really important to think about diversity in research trials that allows us to actually examine for differences, not just across population groups, but also to understand what might be contributing to those differences. And I think in the past, we have unfortunately applied the differences that we see across socially ascribed racial and ethnic groups directly into clinical practice without often giving the consideration to why those differences might be occurring. And I think the clopidogrel is a great example of where the difference may be coming from a genetic variance that may have increased frequency in certain populations. And this actually has something that's really personal to me as someone that's South Asian. And in fact, it has a non-functional CYP2C19 gene and has a family history of heart disease. And so for me, that actually has important relevance. But I think we forget to think about or forget to study what are the social and environmental contributors that might be contributing to the differences that we're seeing across populations. And I would argue that these structural determinants are probably a larger driver than many of the genetic things that are maybe associated or having founder effects in different populations. And so I think this really calls for a big structural change in how we think about funding research and how we support different groups to be able to participate in research, and how we think about inviting community to be equal partners in research as we move forward. And it would be great to have more support around that piece of it.
Great, thank you. And Teresa, would you like to share your thoughts on the first panel?
Huge gratitude for including me in this discussion. I've learned so much already this morning. Let me start by telling you about my favorite pharmacy teacher in medical school all 30 years ago. He was my favorite because I was fascinated by his area of study. He was a physician scientist, and he studied beta blockers. And remember, this is 30 years ago, so we're talking about atenolol and propranolol. So it was fascinating, but he was also, at the end of his discussion, whatever the drug he was telling us about pathophysiology, he always ended by saying, what is a doctor to do? Acknowledging at the end of each session that there are desired effects of our treatments, that there are undesired effects of our treatments, and to be able to be cognizant of both. And then to say, you know, there's so much uncertainty. And as physicians, as clinicians, we are expected to carry that with us and to bring that with us, not just to clinical encounters, but in the ways in which we organize our practices. And so borrowing from that, I think that the next point I'd like to make in response to the wonderful presentations this morning is to challenge us to think of medicine as a social science. There's a lot of biomedical science that we need to learn from. And the social sciences really is sort of where our heart is as practicing clinicians, and how we organize our practices and how we organize the delivery of healthcare. I'll just cite a couple of examples, and then we can move on and may be able to cover some of it in more detail. The first is that we know very well that race concordance and language concordance leads to improved clinical effectiveness. Now, what does that mean so what's a doctor to do? And I'm both a clinician educator as well as a clinician administrator. Well, that means that we really need to challenge ourselves to hire more African-American, Black, Indigenous, Asian American clinicians into our practices, not just into the practice of medicine, but into pharmacy and into nurse practitioner school. Because this is the way that we will actually begin to change some of the structures that you very well described, Dr. Obasogie. And I liked how much is enough. Justice Ruth Bader Ginsburg was asked often, when are there going to be enough women on the Supreme Court? And she would say, when there are 9. And of course, people would be shocked. And she would respond by saying, well, there used to be 9 men and nobody ever raised a question about that. So that's one area that I would bring to you for consideration. The second is that we also see better adherence, better results, more effectiveness in our clinical practice when our patients trust us. And how do we build that trust? Well, one way is by not being the all-knowing, shake your finger, you got to do this sort of clinician, but also working in collaboration. Again, with clinical pharmacists, with other clinicians, with health coaches, to have us really be the place that our patients come to with their questions related to their medical treatment, but also with their uncertainties about all of the things that make their lived experience that is outside, usually thought of as outside of healthcare practice. I think when we do that, and when we do it over time, so not just one clinical encounter or 3 clinical encounters over a year's period, but truly over decades. And again, that's why it cannot only be me, but it has to be the collaborators that I have in my clinical practice. When you build that trust over 10 years, over a generation, so that a parent brings their child, that child brings their friend when they're a teenager because they trust you to treat them in a respectful manner, then that actually begins to make some changes. Thank you.
Great, thank you so much. So I'm going to pose a couple of questions to our panelists, and then we're going to shift over to some questions from the audience. So please start, if you have questions for panelists, please submit them through the Q&A button, and we'll start reviewing those questions shortly. So my first question is for Denise. So in your opening remark, you talked a bit about medical education and your work in that area. And I was wondering if you could talk more about where medical education has been and where it's going with regard to the use of race in medicine. I'd really like to hear you expound upon that a little bit.
Thank you so much for that question. I think there's a lot to say here. I'm going to focus in a little bit on the hidden curriculum as sort of a way for us to think about this. I think of a lot of what we teach is implicitly taught when it comes to race and racism, and has deeply powerful and harmful impacts that have been perpetuated in medical education for a very long time. When you think about the hidden curriculum, I think looking at how we present patient cases throughout medical school is a really illustrative example. So for a long time, there were many explicit racist ways that patients were being discussed in clinical cases throughout medical school. And people, a number of years ago recognized that and were horrified. And the response was, let's take race out of all of the clinical cases. Let's sort of have this sort of colorblind approach to how we teach, and that will solve the problem. While that was certainly well-meaning, and we talk about impact versus intention, the impact was not what was intended, right? The impact was, we first of all centered white patients, and because we're sort of in a sea of white supremacy, when race was not mentioned, students assumed we were talking about white patients as the default, and that was very problematic. There were certain sort of assumptions that were being communicated without actually saying anything. And then when race was mentioned, because race wasn't completely taken out, there was this idea that when it was quote unquote clinically relevant, we could include race. And what that did was, in the minority of times where we mentioned race, there were very kind of stereotypical ways that was brought up. And there was this kind of implicit belief that there were certain diseases that were, for example, Black diseases. And if you know them, then that's what you should think about when you see a Black patient. Otherwise, we're talking about the default white patient. And that sort of propagated these sort of false notions of race as biology, and kind of buttressed these ideas that race is fundamentally a biologic thing, when in fact we certainly know that is not true and is a very harmful thing. While certainly racism, as was mentioned by Dr. Albert, can become biology, race itself, as we've been discussing, is a social and political construct. And so being able to tease those things out is important. I think when I think about where do we go from here, to put people's full social context back into medical education, which is I think where we need to go. I think the important thing to think about is being willing to be transparent with our students about what we know and what we don't know. So engaging students around when we're bringing up race in this case, why are we doing that? Let's disambiguate the many different ways that might be interpreted, so that people aren't leaving a session with false ideas about what was meant when race was brought up. If we are talking about a study that involves race, were the authors able to actually say what race was being used as a proxy for? Is that clear, or is that not clear? Was this good science, or was this not good science? Is race an appropriate proxy in that setting? Being able to have those conversations is important. And then being able to recognize the impact of social determinants of health and racism and experiences of racism, and saying we're talking about race in this case because actually what we're talking about is that. So being able to be clear about why are we talking about race? What are the limits of our understanding in a given situation when we are talking about race, so that students aren't leaving with sort of these misconceptions about how it is relevant in a given situation. I think that's really important. And I also think it hopefully will lead students to be able to have that critical mindset when they go out and talk in the clinical setting or read papers where race is being described. They'll be in the habit of asking these critical questions. Are we in a trap of sort of thinking about correlation as causality? Is race actually the right thing to be measuring here? Is this an appropriate proxy? What do we want to measure? And sort of pushing us forward to ask these really challenging questions and to dive into the complexity that we are in when we talk about these issues.
Great, thank you so much. So my next question is for Tung. So we have spent a lot of time in this panel encouraging all of us to think beyond biology when conceptualizing race. And I want to ask you, so are there potential complications or downside to having this conversation about race beyond kind of biology or genetics being a determinate way of thinking about health outcomes?
Thanks, Osagie. Yes, I do think, this is a necessary conversation. In these kinds of sort of controversial conversations, semantics are used both unconsciously and consciously to move the conversation forward. And they have effects that I think sometimes go beyond what we think. So this whole statement that race is not biology, I worry. I worry because it's stripped of context. And I think for a lot of us who do sort of social work, social related work with medicine, I want us to say race is not biology and biology is not health. Because if we do that, then we understand that we're not stripping the primacy of our system is biology. We think about health as disease oriented. We think about biology as the key determinant of disease and health. And we fund that way, we teach that way, we take care of patients that way many times, consciously or unconsciously. And when we de-emphasize race is not, when we say race is not biology, even though we are well-meaning, I think we're de-emphasizing race, which I actually worry a lot. We don't want to erase race because it matters so much in so many different ways. And so I want us to think about the implications of what we're doing when we do that. That's really the main sort of worry that I have.
So thank you. That really connects nicely with Teresa's previous comments about race, or excuse me, about how medicine is a social science. And I think that's a really important kind of way of thinking about the social and the political and shaping health outcomes. I want to turn next to you, Teresa. So how can we ensure that patients and communities' voices are heard and prioritized when making decisions about how race is used in medicine? Do you have any thoughts on that?
Thank you. Yes. Again, these are not new ideas. We're talking about the 1970s. Clinics without walls. Do any of you remember? Clinics without walls. What does that mean? It means that really the neighborhood is, and I think why is this important in the context that we're talking about here is that aside from the racialized ways in which Black African-American individuals and families and communities suffer in this country, aside from police violence, redlining, food insecurity, inadequate housing, environmental racism, discriminatory hiring practices, which were all mentioned at the beginning of the video, there's also economic segregation, right? So segregation is through economic wealth, but then also in employment, as it has been so clarified by the COVID-19 epidemic and who has fallen due to that. And then educational segregation. Segregation of high quality education in this country is rampant. And so why is neighborhood health important? Why should there be clinics without walls, hospitals without walls? That maybe taking it a little too far. But the idea is that health center, because health is not only the absence of disease, but through health center brings in the voices of the folks that we're trying to care for. Through patient advisory council, and we're reinventing that, right? We've started to reinvent that in the last, I would say, 5 to 10 years, bringing in patient advisory councils into clinics, into public health centers, but also into privately health centers, into medical institutions. And so I think that begins to get at that. We can't only bring their voices, though, we also need to bring their agency for them not only to be able to say to us, this needs to be done differently, but when they say, actually, this is a better way, this is a better idea, this is something that needs to be tried, to have a way for that to have the right amount of power so that we don't take 20 years again to come back to learning the same lesson and having to reestablish community engagement and community trust all over again.
Great, thank you so much. Neeta, so during our first session, one of the keynote speakers, Dr. Bouchard, described some of the biological and genetic predispositions that lead to poor health outcomes in minority communities with regards to asthma and other respiratory problems. So many see this as a controversial perspective, as health disparities regarding pulmonary function and outcomes are deeply entwined with social, political, environmental, and political factors. So I'm wondering if you could talk more about these contextual factors and how they might call into question some of the genetic explanations for health disparities in lung functioning.
Thank you for that question. I think when we talk about lung function specifically, it's important to reflect that that there are many determinants of lung function. And one of the largest contributors is just how tall you are. So individuals that are taller have larger lung function. We also have really good evidence that there are certain exposures that are particularly toxic to the lungs. So tobacco smoke being the most well-supported one, whether that's in utero, over the childhood, or as a smoker yourself, there's a direct effect on how big your lungs will eventually become over childhood and early adulthood, and then also an accelerated effect on lung function as you age. We also have building and good evidence that where you live, what you experience, and your socioeconomic position has impact on lung function. I think one of the largest and greatest body of evidence is for environmental exposures, with one of the best studies coming out of USC with the Children's Health Study. That group not only showed that poor air quality was associated with decreased lung function in children, they also showed through a really nicely use of a natural experiment design that when with EPA regulation and improvement in air quality, we actually saw lung function improve in children. So showing this direct effect, if you take away the toxin, you can actually see improvement in a very short period of time. And so given that these social and environmental determinants are strongly influenced by which racial or ethnic group you are a part of, in that historic and current practices not only dictated where individuals were allowed to live, but also the resources that were invested or in fact not invested in those communities. I think it's really important to acknowledge that the lower lung function values that we are observing in these large population studies, comparing Black populations with non-Hispanic white groups, that these factors, these contextual factors, are likely being reflected in this overall mean deficit. And by using population norms and race-specific equations, we may actually be missing this pathology. I don't want to suggest that that there isn't a role for genetic factors, or sometimes in some instances they can have a strong influence, but I think compared to the overall contribution of these contextual factors that are more difficult and nuanced to measure because we haven't applied the same statistical methoding or the funding on being able to measure factors that occur over a life course and sometimes over generations. We just haven't gotten there with the science to sort of prove this. But I do think that there is a strong component for contextual factors.
Great, so thank you so much. So I'm now going to turn things over to Amy Medeiros, who's an associate professor of history and health sciences at UCSF, and she's going to assist with bringing forth a few questions from the audience. Amy?
Thank you. Okay, I have a question that is meant for each panelist. This person would like to ask each panelist whether they, as clinicians, would use the ASCVD calculator with the race variable included when seeing Mr. Thomas, and if so, what they would say to Mr. Thomas about the basis of his risk estimation. I can call on someone. Perhaps Dr. Connor, would you like to begin?
That's an easy one. Thanks, Amy. No, that's a really important question. Of course, it follows right from what we talked about. And I feel like we've all kind of skirted this sort of practical, concrete question. So I appreciate the person who asked it. I think, like I talked about, transparency and not shying away from complexity being important with our students. I think the same is true with our patients. And if we do have a flattened hierarchy in which we can actually have honest, authentic conversations with patients where they can share with us their concerns about how racism impacts their care, for example, and how discrimination has impacted their care. And we can share with them our concerns about how racism impacts medical research and how things are framed and performed. I think having actually a conversation when we talk about shared decision making, we need to actually have that background conversation first to say, you know, there is this score, it includes race. I think race is being used as the proxy for many different possible things here, and they're not teased out. And I'm not sure you as an individual person, Mr. Thompson, which of these factors you actually possess, I'm not sure. And we need to learn more about you as a person to tease that out. So we saw that great list that Dr. Albert showed of all those different social determinants of health and other factors that may contribute to risk. And being able to sort of talk with the patient about which of those factors he may have to add to what the risk score is telling us, I think is important, and treating that person as an individual, taking the time to learn about them. And then also saying, you know, here, these are the numbers. This is what it says. If I put Black race in, this is what I get. If I don't, this is what I get. We're not sure we understand what that means yet. And let's have a conversation about that and sort of being honest about the limits of our knowledge with our patients.
I can also take a crack at that. And actually, I don't have an answer. After 30 years of clinical care, the first thing that comes to mind when that question comes up is, oh my God, you know, I got 20 minutes. Do I really want to open this can of worms? Even as big of an important thing as it is. And both in terms of like just explaining how race is incorporated into the guideline recommendation, and two, whether or not does that open up a whole discussion about race and racism that I'm not ready to have with my patient. I will say though that vis-a-vis the whole workforce diversity issue, I'm much more comfortable having this conversation with an Asian patient than I am with a non-Asian patient. And I think that's something that as we go forward and figuring out how to do this work, I think we need more diversity in our clinicians and our clinician educators and our researchers, because that enables us to have these conversations without problem. I will say that, for example, I don't have a problem with bringing up race, like Black race, in the decision to talk about prostate cancer screening. But I do have a problem with sort of these other sort of guidelines that seems to be much more complicated. So I'll stop there.
I step in to answer this because I think the challenge for us is that the use of these risk calculators is for a very biomedical decision. That usually is, should we start a statin? And I think the challenge is that these calculators without race underestimate the true risk of heart attacks that we see in African-American communities. It underestimates the true risk of heart disease that we see in poor communities. And then the question is statin the treatment for racism or poverty? Well, statins is not a reasonable treatment for those, but it actually is important that clinicians understand that these are factors that have real health consequences for communities, right? For our poor communities, for our minoritized communities. And so the challenge for how we teach and how we practice is, how do you understand what really is what we are observing, what really has these larger structural factors that are at play that Professor Roberts and Professor Obasogie really point us to, but then not lead us to this very biomedical, well, that means they need a higher dose of statins, because that is the treatment that the risk calculator points us to. And I think that's where it's incumbent upon all of us to think of our patients within the broader context and ourselves within the broader context. And so that's why it's hard. It's not a simplistic answer to that question, because the recognition is still important.
I use that calculator all the time because I otherwise have no idea what to do with statin treatment. And I think it's useful in that sense. That's not entirely true, but it gives me a range. It gives me an idea of sort of whether this person in front of me, what their risk may be for cardiovascular disease in the next 10 years. And I completely appreciate what Dr. Bibbins-Domingo is saying about underestimation and kind of taking that into account and how do we talk to our patients about it? That is a really, I mean, that is an area of study for all of us. I learned the most about this from a couple of things. One is that one of our health workers who has been working with our team in the Family Health Center around improving blood pressure control among African Americans, said to our group once, had this conversation with a patient who were trying to bring their blood pressure to control, and it was a difficult conversation. There were a lot of things going on, and finally, I just said to her, the reason that there's a health educator, is a health worker, is a Black woman, said to her, the reason that we're focusing on you is because Black individuals in general in our community have very poor control, and found that created an opening for conversation that was very rich and that otherwise would not have happened. Now, they were across from each other, and so they knew each other's skin color, but it was more the identifying as, the reason that this is important to me is because I care about you, and I care about our community together. So that has given me the courage to bring up that conversation more frequently. And I think it has gone very well. I think it has informed me, and I think it's helped to build trust. I think the other part of the other thing that I will say is that Dr. Tony Martin, who is a physician in the East Bay, a primary care physician, wrote an article about use of the GFR equation about 10 years ago. I think it's called The Color of Kidneys, in which she talked very poignantly about the ways in which she thought about these conversations with her patients. She's African American, and many of her patients are as well. And about sort of the question that's not being asked is sort of, are my kidneys Black? And so I've always thought of that, and sort of, is my heart brown, or is my heart brown, Latin American? Which of course the race and ethnic factors that go into our skin color and our ethnicity and our heritage are just so many. But I think the ways in which our patients hear our discussion of race, we need to just be really careful and listen to them more, rather than just sort of farming by including language that is going to make them mistrust us even more.
So, Tung, one thing you mentioned in your comments is that you would consider prostate cancer guidelines a bit differently. I was wondering if you would like to expand on that.
Well, maybe I didn't really mean that it's biologically different, but it's just so clear. I do a lot of cancer sort of prevention work, and the data on, the disparities in prostate cancer and how we think about it in terms of recommending the PSA or prostate antigen tests is so complicated. Race does factor into it, at least for now it does. And we have these conversations all the time with our communities. I do some work with, I don't do a lot of work with Black communities, but we do, our cancer center does. And our Black patients that we engage with, the Black community leaders we engage with, do want to emphasize that, yes, being Black puts you at higher risk for prostate cancer. And yes, you should think about prostate cancer screening differently than a white person would. That's the feedback we're getting. And so for me, that feels comfortable that I can use that particular way of looking at race in this particular clinical situation. I do want to say, though, that the point I was making there is it's important that who is involved in these conversations. Again, I'm very interested in sort of who is the dominant group driving the conversation. And even as a great group as we are here in these conversations, it's still very much academic focus, very scientific knowledge prioritization. I think communities and patients' perspective should be a part of this conversation.
Just to add to what's been discussed already around the use of the algorithm for statin therapies, one of the piece in thinking about patients with asthma and addressing whether or not we need to increase their treatment versus talk about other sources is here. When you have someone with high cholesterol or with poor asthma control, is trying to think about the social or environmental contributors that might be leading to that being out of control, and why those might be different for different groups. So housing security, food security, having access to healthy foods and vegetables, access to exercise, both being able to do it safely in your neighborhood or having the time. Sleep-wake cycles, we know that employment history has an important impact on people having to work at night versus during the day. That has disruption to your ability to manage your lipids. And so I think when we see that race is being incorporated in these guidelines, we have to really, really reflect and think about what is it actually measuring. And, to echo both Kirsten and Tung, like these differences that we're seeing in populations should really have us questioning what are they reflecting, and then how do we talk with our patients about this. And so in my own practice, asthma is easy because it is in the guidelines to ask about environmental exposures. I end up doing that early, day one. In the guidelines, it's recommended to do it only after the person has uncontrolled asthma for some times and you've already done step-up therapy. I think it's a little bit backwards. There's good evidence if you address environmental and social factors, you can get good asthma control 70% of the time. And so I think the way we talk about the social factors should be the same way we talk about BMI or blood pressure with our patients.
Great, thank you. Denise, did you want to add a few comments?
I just wanted to add one thing, kind of echoing what Teresa was saying, and something I said earlier about talking with patients about their experiences in healthcare around discrimination and racism. I think it does feel like opening Pandora's box, certainly in a 15-minute visit. It does, but we talk about very complex things with patients. We talk about end-of-life care. We talk about sexual history. We talk about things that are very complicated and challenging to talk about because they're important. And I think we actually need evidence-based approaches to how to open up these conversations with patients about identity and background and about experiences in the healthcare system. I don't think we have all the right language yet. We certainly don't have the training. Denise Davis, who is one of a wonderful faculty member here in the Department of Medicine, has developed some conversation openers to talk to patients about their background and identity and how that's impacted them in their lives in very positive ways in terms of how their resilience and their strengths from their community, as well as potentially in ways that have been challenging in the healthcare setting. And I hope to see in the future that we continue to kind of push what are the right ways to open these conversations, and we don't shy away from them because they're in the room, they're the elephant in the room. Patients come in to the healthcare setting worried about this. It's not like we're opening up something that they're not already thinking about many times. So I do think that's important, and I think that's research is needed really to help us do that well.
Great, thank you. Amy, do you have another question from the audience?
I do, thank you. This question has to do with the structural and social factors that are sometimes overlooked when we talk about, when we use a reductionist clinical research frame. And this is for the entire panel. Can you please comment on the lack of use of and support for social science research in academic medicine that would be better prepared methodologically and theoretically to understand the social structural factors driving biological responses? How can we change this in the moment of recognition of structural racism and racism over race as causative? You have 1 minute. I'm just kidding.
I totally think that we need to spend a lot more money, prioritize research, not just on the social determinants of health, but exactly the kind of things that Denise and Teresa is talking about. Like, how do we communicate? How do we talk to people? How do we include all of these things in the work that we do? We just don't have enough money. I mean, we can remap the human genome. We're nowhere near where we need to be for this work to happen with an adequate level of scientific precision. I have to say, even like let's say we wanted to replace or moderate the effect of race with racism. Do we even know how to measure racism in a way that's validated or across populations, things like that? These questions just have not been answered scientifically, and we're not investing in it. We're having this conversation where we're not going to invest in the most important things that are determining health.
And I will just add to that in addition to thinking about how these structural and social determinants impact health, we also at the same time need to think and promote interventions both at the policy, community, and individual level that actually can change or impact these social and structural determinants in a way to improve health. There has been a large body of research that do show that social and structural determinants, including racism, impacts health. And we, since I see Dr. Perez-Stable has been able to join us, the NIMHD just put out a really nice RFA on the structural determinants of health and putting funding towards it. And part of that RFA is a focus towards interventions. And so we also need to move beyond describing the problem and start focusing towards interventions, both at the policy, community, and individual level that brings in communities as equal partners. And that needs financial support. We can't expect people, just like we as researchers are funded to do our job, we need to fund community members in the same way to be part of that conversation and part of directing those research initiatives.
I was going to add too that when you think about anti-oppression and anti-racism, that includes other ways of knowing besides traditional, Western, often white ways of knowing, right? So that includes storytelling, and it includes fields outside of medical education for sure. So if we're serious when we say we want to bring an anti-oppressive lens to medical education, I think we absolutely need the expertise of people outside of the very narrow biological view of health. As been brought up, health is much more complicated than just biology. And so I don't have an answer to the funding piece or how to really do this, except to say I completely agree it's important. And if we're serious about moving in this direction, we need to accept that RCTs and are not the only type of knowledge that we should be learning from.
Yeah, just to add to this, from the pedagogical side, so I am a faculty member in the joint medical program between UCSF and Berkeley. And that program has been around for about 4 decades, and it was intentionally designed to have a more integrated process in teaching medical students in ways that brings in the social sciences and humanities as a central part of their medical training. So our students, while they're getting their initial kind of training in both the sciences and clinical trainings, they're also receiving or have the opportunity to explore the health sciences and how social and political and economic factors impact health by being able to spend 2.5 years on Berkeley's campus and making those connections between their medical training and other parts of the university. And it's a phenomenal program and it's unique, but still, we have a lot of work to do in making sure that integration of the social sciences and humanities really speaks in meaningful ways to their clinical training. And so, a lot of my work is constantly trying to find ways to make sure that the work that you're doing in my class that tries to put medicine in its broader historical and social context, making sure that that's meaningful as a way to inform the way that they interact with patients or interact with other physicians as part of their education. And so this is to say that, even in a space like the Joint Medical Program, where I would like to think that we are doing it in the best way or the most advanced way possible, we still have so much work to do in making sure that we help our students fully understand and appreciate those direct connections between the social sciences and humanities and the work that they would do as trained physicians. And I think that's just something that all of us as educators can continue to work on.
I couldn't agree more. And so I'm going to just add my voice to say yes, yes, and yes. I think that just the social sciences have scientifically shown us again and again how we can contribute to people's health. And we've excluded them, sometimes on purpose and sometimes unintentionally, from the training of the next generation of healthcare providers. Again, I'm going to just name a couple because I try to have these instruct my day-to-day practice. One is that we know that structured social learning and learning to learn at the age of 3 to 4 has huge and profound and long-lasting impacts for social determinants of health and for ameliorating some of the usually called negative social determinants of health. And then the second thing is that if we agree that economic segregation is part of the problem and part of contributes to poor health, then having a guaranteed income is something that has been studied by social scientists over and over again and shown in cases where it's tied to an actual health practice, like getting immunizations, it makes a difference. But at every single time, it always adds to folks' sense of well-being. So even if we don't meet the metrics, people feel better. They have more agency over their day-to-day lives. And so that means that they will be healthier. And so again, I couldn't agree more and wanted to add that.
Great. Oh, go ahead.
I'm sorry. No, I was just going to ask if there are any other comments on this question, and if not, we can move on to the next one. Okay, Amy.
Okay, another question is actually a couple of them together, and not only from this session, but from the last one. And it has to do with many of our attendees being students. And we got asked this question last time and this time about what can students do to raise their concerns and ask critical questions about race, racism, education, causes of medical mistrust, and more during classes, and to instructors if these topics are not openly being discussed in the curriculum, and then also to in clerkship. So hoping that you would be able to provide some advice for our students who are tuning in today.
I'm happy to start with that. What I was going to say is that feedback, when done well, is based on relationships and mutual respect and trust. And so I think the Academy in Communication and Healthcare is a fantastic organization that helps us think about how to talk with people, right? How to talk with our patients, how to talk with our colleagues. And a really important thing that they have kind of recoined the frame feedback to relationship-centered feedback. So I think that's the first thing I would say, which is that being able to provide constructive feedback or challenge or to bring up challenging conversations really requires a investment in other people as humans and a recognition of your kind of common beliefs and values. I actually think one thing we've been talking about is we don't really teach how to provide feedback or how to receive feedback all that often throughout medical education. And it's actually critical to continuing to improve as clinicians and as members of clinical teams. So I think that's something that is needed, is actually structured curriculum to help all of us learn better how to do that work. I think in the meantime, the thing that everyone always brings up is humble inquiry, right? Humble inquiry is a helpful kind of thing to keep in mind when you are bringing up challenging questions, which is to say things in the frame of, I'm curious about this. I'm noticing that we're using race in this way, and I'm curious to learn more about it. It can be a very helpful way to kind of open conversations that does not immediately lead to defensiveness and fragility on the part of people that are receiving those questions. So I think focusing on your shared values and beliefs, the relationships that you have, and then using a frame of humble inquiry is a start. But I think in reality, what we need is actual training of learners as well as faculty how to have these conversations.
I want to make a comment. Whenever there's a question that relates to power dynamics, I always want to challenge it. Like, why is the onus on the students to learn how to do this better? Every time we present stuff to our senior faculty and our senior researchers, we find that they're incredibly deficient. They don't know how to talk to patients. They don't know how to work with communities. They don't know how to deal with race and disparities and equity. And we somehow give them a pass, like, oh, you know, and it's on our students to learn how to do it. I think we need to hold people to be accountable. And it goes beyond just DEI training and implicit bias training. Those things are really necessary, but it's just not sufficient. And so we need, when we think about medical education reform in this area, it's about our faculty. It's not, so it's, you know, I think, you know, our teachers are great and our students are great, but it's the other people who interact with our students on a regular basis that are actually driving a lot of this conversation.
Tung, I really want to emphasize the point that you just made because it's so important. One of the conversations that I always hear from faculty is that, well, the race conversation is just too hard, so I'm not going to address it in my class. And I think, as you said, we really need to challenge that point and realize that as university faculty and researchers, we are engaged in cutting edge research that is transforming the world, right? So you're a cancer researcher. I do work in law and reproductive genetic technologies. All of us on this panel are doing phenomenal work. We are at institutions, UCSF and Berkeley and other places that are doing critical work that is just changing the way that we live. If we can engage in that work, we can engage the race conversation. And it's one thing for something to be technically difficult, it's another thing for it to be politically difficult. And we need the courage to engage the politically and socially difficult questions in ways and with a level of seriousness that we address other parts of our research endeavors, because it's so central to what we do. And moreover, when we neglect to address those issues and questions, we are failing our students, we're failing our institutions, and we're failing our communities. So just as important for us to build competency in the kind of technical skills that we train our students in, so too is it important for us to build competency in a way for our students to be able to engage the world around them, which includes being able to have sophisticated and meaningful and authentic conversations about race and racism. And that's a huge responsibility on us as researchers, scholars, and teachers. And it's a huge responsibility for institutions that we work for to take seriously as well. So I think the point that you're making is so critical for us to rethink and reimagine what our responsibilities are in teaching the next generation.
I will, I want to echo the power dynamics. I do think this needs to be come from the top, the leaders, to have this actually translate. I do know and recognize that that's slow and frustrating at the training level. And so sort of pragmatic suggestions for trainees, understanding that the medical education system is incredibly hierarchical. Your evaluations are dependent on your interactions with your faculty and clinical instructors. There is an overemphasis on being the stereotypical best student when you're on rotation. So questioning practices and decision-making is not favored. Humble inquiry is one way. I have seen the power of anonymous feedback, especially when it comes from large numbers of trainees, and also banding together. Remember, UCSF did not make this focus until the medical students formed the White Coats for Black Lives, right? That pushed UCSF to change focus and do the Difference Matters movement. And so that was a trainee coming from our students' effort. And so I think there is power. I've also seen it happen both at the resident and fellow level as well, where changes happened. The other way I think it's a way to bring it in is through discourse and academic discourse. Just like we talk about seminal articles and RCTs, we should be including in our journal clubs, which are often brought by the students and trainees, on those that highlight health disparities and the social determinants and structural determinants of health, and talk about them at the same scholarly level and their implications for clinical practice on a regular basis. And so those are efforts that can be done and more tangible right now as we wait for this sort of slower process for it to happen from the leaders.
I do want to quickly add, just to reflect on your point, Tung, faculty development is a core part of anti-oppression work for sure. I think the key thing though is that it is slow. I mean, that's reality. So I think we do need things that you just talked about, Neeta, which are what do you do in the meantime while we're working on up here, as that hopefully begins to change culture? What do students do in the meantime tomorrow? And I think that's a challenging place to be for students.
I've been a pitch for this. We don't have a diverse enough academy, and we've been waiting for the pipeline to fill that lack of diversity, and it's taken forever. And I'm not even sure that we're all that successful. I mean, at UCSF, I think we are doing a good job. I just feel like we need to introduce more diverse voices into the academy. I think community engagement, diverse community engagement, particularly of community leaders with lived experiences, and as you mentioned, Denise, other kinds of knowledges besides academic scientific research knowledge into our education system is important. We need to introduce them, we need to reimburse them, we need to prioritize them. We need to treat them as value teacher, just like anybody else.
Great. So I believe we are at our time limit. So I just want to thank all of our panelists for these extraordinary comments and reflections. This has been, I think, really useful and productive, and I hope to be in conversation with you all in the future. I will turn things back over to Kirsten.
Well, you certainly have an open invitation from us to continue to engage us in these conversations, and we really appreciate both your commentary and Professor Obasogie, and my thanks to all of my colleagues, Dr. Connor, Dr. Villela, and Dr. Nguyen, and Dr. Thakur. Thank you very much. We're going to transition to some closing comments from someone who is well known to us at UCSF and now known to the rest of the country, and Dr. Eliseo Perez-Stable, who is Director of the National Institutes on Minority Health and Health Disparities at the National Institutes of Health, and a general internist and a colleague and mentor to many of us at UCSF. We've talked about many of the factors that we've talked about during the course of the day today really relate to how we think about the knowledge generation we need in this area. And as one of the largest funders of this type of work at the NIH, we were really pleased that that Dr. Perez-Stable would agree to join us. He's going to give some remarks, and then I will come back and talk with him briefly about this, and then we'll close out the session.
So thank you very much, Kirsten, and it's wonderful to see old friends. And I do plan to try and join you next week as well for the earlier part of the session. This is always of relevance to, well, to everything I do, that's for sure. Now let me see if I can get my my slides up. I have to open them first, I guess. Hang on a second. Go back to here. We've all become Zoom experts of sorts. So I did promise Kirsten that I would only speak for a few minutes, so I limited this to, I believe, 8 or 9 slides. And apropos to the conversation focusing a lot about clinical teaching and education, I will try to emphasize those points and not from a purely a research or scientific perspective. Everybody can see my slides? Okay. No?
Yes. Yes.
Okay, good. So this is the only sort of standard definition slide, just what we use at NIH. The populations with health disparities are listed at the first four bullets. I would add that the first three were part of our original legislation in the year 2000. So you learn in federal government, you can't change things that are mandated by congressional law. So those are there to live. But just to reiterate, all racial ethnic minorities as defined by the US Census, all poor people of any color, rural residents, and I added the qualifier of underserved when I started in MHD. And then in 2016, sexual and gender minorities were added to populations with health disparities with the qualifier for NIH research purposes. And we use the operational definition of a health outcome that is worse in one of these populations, usually compared to a reference group, as defining a health disparity. Then we also embrace the notion, I think this was critical in getting over the barriers for sexual and gender minorities with the department at the time under the Obama administration, that all these populations have a social disadvantage that result in part from being subject to discrimination or racism, and also being underserved in healthcare. So it is fundamentally important, in my view, that race ethnicity is a self-identified social construct. That's a given. I don't believe that every NIH leader or institute director or scientist really in their heart of hearts believes that, but at least they don't contradict me in public. I also believe that this complicated social construct that we use and operationalize, and actually has global implications, is not a US issue, as I was told by colleagues in Latin America 30 years ago, has behavioral, biological, and environmental components that are important, as well as social interaction components. Race ethnicity differences are really a potential tool for discovery science at all levels. And I think it's something that has been sort of at the core of my own research career from the start, at a time where I did not have these kind of concepts at all. However, it's important to really embrace the idea that the legacy of racism and discrimination, as well as individual experiences, really do travel with this self-identified race ethnicity. So why does this construct explain so much is the question. So it's not that race ethnicity is causing anything. I think that's the wrong way to operationalize it, and people are debating that. It's an association that we observe, and therefore that should lead you to either other inquiry scientifically, or interventions, or ways to manage either programs or, in this case, patients. I think equally important to consider in this discussion at all levels is that socioeconomic status or social class, to use the social science terminology, is equally important as self-identified race ethnicity. And we have really fallen most short in this concept. Many clinical investigators or clinicians either believe they know the race ethnicity of their patient, or ask, or in a research context, sometimes people ask, but they very infrequently know or ask about social class. And I think this is a major deficiency that needs more attention. Independent of that, stratifying by socioeconomic status by race ethnicity is even less done in research. And I think for a clinician, operationalizing that in how you communicate with patients. This is a simple way to illustrate the point about the importance of socioeconomic status, taken from data from the IRS, used by a number of different economists over the years, Rash Chetty maybe most recently. If you're under $25,000 in household income for a family of four, this roughly is the poverty level in the US. Roughly about 15% of Americans live there. You're 3 times more likely to die from anything than if your household income of 4 is 115,000, which is definitely well off, but you probably still will get a recovery check coming up because you qualify. So you're not wealthy. That's the point. These predict a lot. I think you're all familiar with this. I saw that from the schedule, the agenda, what some of these were being discussed. There's prediction of life expectancy and mortality that we don't fully understand. African Americans have more strokes with the same level of blood pressure when compared to whites. And I don't know if that's because of John Henryism, racism, or socioeconomic status, but the data are very, very robust. So that to me means that Black Americans should have their blood pressure better controlled, or at least as good, well controlled as whites. And we don't do that. And that's where the deficiency comes in. And poor people generally smoke more, drink more, use more substances, have higher body mass index, higher rates of most chronic diseases, not all, but most. And understanding that, I think, is important. Maybe the guaranteed minimum income would go away to address that, but there are also other interventions that could be considered. And then even within the disease, such as diabetes, we see that all minority groups, which all have excess rates of diabetes, including Asians, have less heart disease. And this is data generated in part from UCSF on the Kaiser Diabetes Registry over a decade ago, and all have more end-stage renal disease. Now, why is that? So less heart attacks, less heart failure, but more dialysis. And understanding that, I think, scientifically will be relevant in this case. We also, have to consider this complex playing field of social determinants that have become quite, let's say, getting a lot of attention now at the level of the Department of Health and Human Services. And so more will be coming from this. And this is just a brief summary of the individual determinants up top. It's not exhaustive, but you can see where I'm coming from on this. And then the structural determinants, which have been mentioned, related to all the issues of where we live and play, housing, green space, the broadband internet. Did we really think it was that important until about 15 months ago? Economic opportunities, transportation, et cetera. NMHD actually embarked on a project 3 years ago that to develop standardized measures for the social determinants. We finished one major component of it. A couple of UCSF faculty were part of our expert panel, Alicia Fernandez and Paula Braveman specifically. The measures that were vetted are on the Phoenix Toolkit website, and the link is there in the slides. We're continuing this project, and staff have developed a set of measures that we will launch through the Phoenix process to try and identify and vet measures. Most of them are focused on the structural social determinants, since the individual ones generally have mostly been covered. So on patient-doctor communication issues, I'll start with just saying that in my own practice, and believe me, I'm now getting to the point where I can no longer have any credibility, since it's been almost 6 years since I took care of patients directly. I always started my visits with patients with, who are they? And ask them about their background, after the initial sentence of why are you here, your checkup or complaint, and make sure that there wasn't any acute issue that I needed to immediately pay attention to. I wanted to know their story. So the way I said that to students on the wards and in teaching was get the social history first. And when you present a case to me, present the social history first after you do the one sentence on the medical scene. And I value that. I think that connects people with patients. It's their story. You tell them, where were they born? Who are they? What do they do? How far do they go in school? You get the essential elements. Frequently in that interaction, I shared my own path in some ways, particularly in people who spoke Spanish, but not exclusively. And I found that most of the time to at least have one response to Denise's question of how do you bring this up with patients. I do think that we know the power of patient-clinician communication. It is an understudied area. It's directly linked to better satisfaction, better adherence, better health outcomes, and less malpractice events in one well-done study. And about a third of patients, again, disproportionately more minorities, have trouble understanding their doctor, say their MD did not listen or had questions they could not ask. And this is when they speak the same language, these differences are magnified when you're going through an interpreter. And then to enhance communications with patients, knowing who they are, I think is really essential in getting some precision in patient-clinician interactions. So I would argue that knowing someone's race, ethnicity in clinical care and social class, as well as their lived experience, what did they do, what's their family like, is really part of, is a sort of a starting point for developing good rapport with patients, independent of the setting. Maybe acute issue in the emergency room doesn't really allow for that, and maybe it's not where you want to, but in the hospital or in the clinic or in a specialty setting or in a primary care setting. We've been talking about racism, and you're all familiar with this issue. This is data from 6 years ago. It could be much equally bad now or worse. When asked by Kaiser Family Foundation National Survey, and this was updated from a prior survey they had done about 15 years earlier, they asked about the past 30 days, any events in any of those settings listed there, and you could see that over half of African-American respondents and over a third of Latinos all said that they had experienced this in the past 30 days. So I think I show this in almost every talk I give recently, and it's really to establish the knowledge that racism, we're not over it. It did end 150 years ago. It did end when we elected an African-American president. And certainly the issues of 2020 brought this to light, but these are not new problems, and we've been dealing with this for many, many years. Operationalizing this as an interpersonal, internalized, and then perceived racism, which is another way of looking at some interesting studies have been done, mostly with adolescents, asking them about what they think is out there, not what they experience. And 40% of 11th graders in Los Angeles, a majority of them non-whites, perceived significant societal discrimination against a variety of factors, not just race, ethnicity, including disability, sexual orientation, and gender. And then secondhand effects, another concept that hasn't been studied extensively, although there is some literature on this. How does a victim of discrimination impact their loved ones? So those of us who've done tobacco are familiar with this concept, and clearly it could have effect, particularly on young children. This was mentioned earlier, and I think we're really enthused that this came out. It came out with, I think, almost all institutes and centers at NIH endorsed it, and committed funds. So it is an RFA, and we have a significant amount of funds available for funding grants this fiscal, or actually in fiscal 22, sorry. But it will be this year that people will need to submit. This has probably been discussed in this group, but this recognizing that structural racism A exists, and B, we should do something about it. We really need interventions. 5 years ago, when I arrived at NIH, I thought, well, is this really a research construct? Can we study this? And I've been having this back and forth discussion about this for years with colleagues. No one really had an answer. Some people thought, well, we should propose it as an organizational theme, and the contour, that perhaps in some ways, the cultural competence being looked at as another concept that could, on the opposite end of the spectrum. But regardless, I think about these issues, so I won't dwell on this. And those are 3 bullets of topics that we outline in the RFA that really emphasize this. We have a special issue of ethnicity and disease that's being published, where we wrote a couple of commentaries, and David Williams also wrote one. The papers in and of themselves are not so necessarily innovative or groundbreaking, but it's time we start to do this conversation from a science perspective, as well as what, not just describing, but also really emphasis on intervention. So I'll stop with that, and hopefully we'll have a few minutes for more conversation.
Thank you so much, Eliseo. That was really terrific. And it reminds me, just watching the ways in which you've you and your team have really transformed that institute to both expand the populations that we think about with disparities, as well as to help us to really focus on the multi-layers, the multifaceted ways in which we know that these large differences in health that we observe across populations really come to be. And I really love your rubric and a lot of the things that you have on your website. But
Thank you.
Other institutes of, you work with other ICs at the NIH, and one of the themes we've been exploring in this session and the past one is both race as a social construct that, as you say, for your definition, includes biology, but oftentimes at the NIH, by the very nature of what it does, gets reduced to biology in the way other ICs might, because we tend to be reductionist in our biomedical research. That's the shorthand for it. So what do you see as your role, not just in framing the research for us, but in your conversations with the other ICs to sort of broaden this concept of race, or at least avoid the sort of biological determinist view of race?
So thanks for that question, Kirsten. I can't not say that anyone has sort of tried to counter my perspective. Probably the group that I've had the most conversations about at the leadership level has been genome, and it really began from day one. And we certainly don't agree 100%. It took me a while to realize that, but they're also not coming out and saying, we don't think you're this race because your ancestral markers say otherwise. NHGRI and NIMHD co-sponsored a workshop, probably, I think it was 2016, all these years blend together. And we had a number of high-profile people come, including, I think Esteban was part of that conversation, Alice Popejoy. I mean, there were David Hayes Bautista. We had a number of conversations. And I think the conclusion from that workshop was that self-identified race ethnicity was the gold standard, and that we weren't questioning that. That there were biological components that were relevant to you to look at from a discovery science perspective. And I think in the pharmacogenetic realm, they clearly have had important impact on certain conditions. And then the third conclusion I can draw from it, and we never actually published any kind of a summary, there were some documents, was that the reality is that it's unsatisfactory to refer to self-identified race ethnicity. People felt like, oh, we need to do more. We need to do more exploration, more qualitative work. What does this really mean? And so that was sort of one of the outcomes of that. And so I can't say that people are opposed to it. I don't see Francis Collins getting up and saying this in public, but he certainly isn't contradicting it. I don't know if that answers your question.
No, it's a hard one. So I'm gonna.
There are other people at NIH now. People may not have followed, besides Lindsay Criswell, who came over from UCSF and is the newest newbie. Shannon Zenk, who's a population scientist, the director of National Institute of Nursing. Michael Chang is the director of Eye Institute. For the first time we've ever had Eye Institute interested in the issues we're focusing on. He's an ophthalmologist, tech, informatics kind of person, but and Deb Tucci is the otolaryngologist, an actual surgeon, is a director of the NIDCR, the Hearing Institute. And so I think that there's sort of a new generation of leaders at NIH with perhaps a less reductionist perspective, just because Francis is actually a pretty open-minded person, and he's the one who makes these decisions. And otherwise, we're not stuck in one perspective here. So
that's great. That's great. We're also, I think, many of us really happy with the RFA on structural racism that came out, and really understanding the health effects of structural racism. But as you alluded to, you'd like to see more than moving just beyond description to actual intervention. And if the interventions, by definition, are highly likely to be structural in nature, how do you see that in the way that the NIH has typically thought about interventions, which tend to be for individuals, right? I mean, because it's very much in the biomedical mode.
No, that's a good point, and I think there is a consensus that whatever is going to be done here, we're going to depend on you, our great, innovative, and bright scientists out there to come up with ideas that are out of the box. It may take other mechanisms besides this initial RFA, and we're working on that. But I think there's a clear understanding that we do need to address issues using other sectors of government and society. So you can't get at housing or transportation or green space without involving other sectors of society. And I think there are generally two areas, and you probably all have heard this, that may seem accessible for change, for creating change. One is actually organizational and relates to not just institutions, but healthcare systems. And I think that's more feasible to think about with the kind of mechanisms that we have now with this RFA in terms of R1s. And the other is thinking about healthy communities. How do we get to that? I think there's enough evidence-based interventions of what it takes to create better health in the long term, and yet we can never really evaluate what the package would do or how we can make a difference in communities. There are some examples out in society, but they're just too few, and that I think that those are two areas that would. So more is to come. This is not the only RFA. We had this RFA ready in September, and it got put on hold because of the executive order. And we are now, I think, putting it on hold had the unexpected advantage of getting every institute on NIH to endorse it. And actually, one of the reasons that happened was because Francis asked people to do that. And although I think many would have done it anyway, having him say it in a IC directors meeting, move people to act rather than wait for us to ask them. So
that's terrific. Well, I know many of us really appreciate you and your leadership and the Institute continuing to push these issues forward. So thank you, Eliseo, for taking the time to join us today and for your comments. And I hope you're able to join us for the next session as well. And I think with that, we will conclude this really terrific day. And my appreciation to all of the speakers, to all of the panelists, and to all of the audience members who really, I think, came through with some terrific questions. This is the first of our sets of case studies. A week from today, we will have two case studies, one on EGFR, glomerular filtration rate, and one on polygenic risk scores. Sign up. The video for this event, as well as the video which is already on our website for the first session, for those of you who've missed any parts of this series. And then again, if you're interested in continuing to extend the discussions at any of our UC academic health center campuses in the area of how our reflections on the use of race in medicine, how that might impact medical education, clinical practice, or research, I'd urge you to sign up for session 4 so that you can take part in those discussions. So thank you very much, and I hope you all have a good rest of your day.